It really is a pleasure to see a lot of familiar faces in the audience now after about a year of working at Rush, and I'm really happy to be here today. And I'm going to be giving just a brief overview of Parkinson's disease before you guys get to all of the fun lectures. So this is probably going to sound very familiar to some of you, but hopefully it will be helpful in reiterating the information that you already know about Parkinson's. So from a big picture perspective, for some of you who are new to the Parkinson's disease and movement disorders clinic, I just want to introduce you to what movement disorders are and why we as neurologists are called movement disorder specialists. And so movement disorders are characterized by abnormalities in, I'm sorry, I haven't changed the slide. Where is, okay. Here we go. Movement disorders are characterized by abnormalities in voluntary movements or the presence of involuntary movements. And for the most part, these arise from inherited or sporadic diseases of the nervous system, in fact. And for the most part, they arise from structures deep in the brain. And that's why we as neurologists are called movement disorder specialists. And our main focus is diseases of voluntary and involuntary movements. And so here's a brief outline of what I'll cover today. So we'll briefly go over how to make the diagnosis of Parkinson's, who gets Parkinson's and when, what happens in the brain, the disease stages, and we'll kind of review some common non-motor symptoms of Parkinson's. And I'll end with a small focus on falls and falls prevention. And so just a little history on Parkinson's disease. So Parkinson's was first described by this British surgeon named James Parkinson. You've probably heard this a million times, in an essay on the shaking palsy. And he wrote this based on his observations of several patients that he observed in the streets of London having a similar syndrome that he labeled the shaking palsy. And many of these patients he described as having tremulous motion, bent forward at the trunk, and having a propensity of walking from passing from a walking to a running pace, and the senses and intellects were spared. And so thereafter, by the 1860s, a very well-known French neurologist and anatomist, Jean-Martin Charcot, characterized the cardinal feature of Parkinson's, which is bradykinesia. And bradykinesia means slowness of voluntary movements. And then nearly a century later, we were able to do enough research to really figure out what is the neurochemical basis of Parkinson's disease, and that is a dopamine deficiency. And so what is Parkinsonism? And so Parkinsonism falls into this category of hypokinetic movement disorders. That means too little movement. And that's compared to hyperkinetic movement disorders, which means too much movement. Under hyperkinetic, one of the more common movement disorders is essential tremor. But Parkinson's is on the other realm. It's hypokinetic. And so the most common cause of Parkinsonism, which is a clinical syndrome, is Parkinson's disease. And then rarer forms of Parkinsonism include things like Lewy body dementia, multiple systems atrophy, progressive supranuclear palsy, and cortical-basilar degeneration. So you might hear us talking a lot about Parkinsonism at your appointments, and you're wondering what does this actually mean? And so it means it's a clinical syndrome of certain features that we see on your exam, but 90% of the time, 80-90% of the time, Parkinsonism is due to Parkinson's disease, and then there's these atypical forms. And so these are the clinical features of motor features of Parkinson's that helps us make the diagnosis of the condition. So in order to have Parkinson's disease, you have to have bradykinesia, which is, again, that slow, decrementing voluntary movements. That is the cardinal feature of Parkinson's disease. And then you have to have at least one of these three features: rigidity or muscle stiffness, tremor, which usually is a rest tremor and often starts asymmetrically on one side, and then postural instability, which really manifests as imbalance and fall risk. And so these are two acronyms that might help you remember all of these features of Parkinson's. So this is how we diagnose Parkinson's disease. And so in addition to us figuring out whether our patient meets those criteria that we just went over, we also ask a lot about these supportive criteria for the diagnosis, these little clues in your history that helps tell us whether you have Parkinson's disease, idiopathic Parkinson's disease. And some of these include symptoms beginning asymmetrically, just on one side of the body, a progressive course, so things slowly getting worse, this very characteristic rest tremor that Parkinson's patients may have, having a good response in terms of symptom control to levodopa, because like I mentioned, all Parkinson's disease is due to a levodopa deficiency. Having gait problems that include things like freezing and shuffling, having a stooped posture, having a quiet or rushed voice, which we call hypophonia, and then having things like masked faces or decreased facial expression, and even something as small as having a progressively small handwriting over time. These are all kind of clues that maybe a patient has Parkinson's disease. And so who gets Parkinson's? And so right now, Parkinson's is actually considered the second most common neurodegenerative disease after Alzheimer's disease, and that's primarily because of our aging population. And so about 1 to 2% of people over the age of 65 are diagnosed with Parkinson's, and 3 to 5% of people over the age of 85. So as you can see, the biggest risk factor for Parkinson's disease is increasing age. And right now, there's about 1 to 2 million people in the U.S. and Europe with a diagnosis of Parkinson's, and it does tend to be a little bit more male predominant, so more common in males with a ratio of 1.5 to 1. And these are, you'll see at the bottom, some prevalence and incidence numbers for the state of Illinois. And so when does Parkinson's occur? Like I said, the most common risk factor is advancing age. So the average age of Parkinson's is actually 65, and it's very rare to have Parkinson's before the age of 50. And so when we see patients who are young onset, who present at the age of 40 or below, we categorize these patients as early onset PD, and we think about genetics possibly being involved. Please remember that most Parkinson's disease, which we call idiopathic Parkinson's disease, is not genetic in origin as far as we know right now. But these young onset patients, we always have to think about their genetics. And so about 10% of Parkinson's disease has been found to be genetic. And we have about 17% chance of finding a known mutation that is causative. And here are some of the common mutations that many researchers are studying: Parkin, PINK1, LRRK2, and GBA. And so we only really consider genetic testing if you have a known mutation that runs in your family, if you present at a very young age, about less than 40, and if there's a specific ancestry that might be suggestive of one of these mutations. And so most Parkinson's is what's called, again, idiopathic Parkinson's disease. And what we mean by that is that we don't know the cause quite yet. And again, this is 90% of the cases of Parkinson's, and the other 10% could be genetic, okay? So likely we think that the cause of idiopathic Parkinson's disease is some combination of genetics and environment, a genetic predisposition towards Parkinson's, and then an environmental factor or several environmental factors kind of pushing you over to developing the disease. And we know that because of a lot of studies that people have done on environmental exposures that are linked to Parkinson's, for instance, Agent Orange in the Vietnam veterans, and various other pesticides, herbicides, and then also solvents like degreasers, historical dry cleaning solvents. These have all been kind of linked to Parkinson's, and also head trauma, repetitive head trauma, for instance, in someone like Muhammad Ali. And so the common feature in all idiopathic Parkinson's disease is this dopamine deficiency. And so where does this come from? So it essentially results from an abnormal accumulation of this protein called alpha-synuclein. And so this abnormal accumulation results in Lewy body formation in the brain cells or the neurons. And that's why you might hear some of us calling Parkinson's disease a synucleinopathy or a Lewy body disease. That's where those words come from. And so ultimately, there's a loss of those neurons that produce dopamine in this area in the brainstem called the substantia nigra that you see pictured here. And dopamine is extremely important in the brain, in those deep structures in the brain, for movement. And so the motor symptoms of Parkinson's begin when about 50 to 60% of these dopamine-producing cells are lost in the brain. And here's just some other brain pathways can indeed be, dopamine is vital to other brain pathways as well, in addition to movement. So first and foremost, it's movement, but also dopamine is important for pathways that have to do with cognition, reward and motivation, as well as pleasure. And so these might come into play when we talk about non-motor features of Parkinson's. And so one other thing that I want to discuss briefly, just because there's been a lot of hype around this, is where does Parkinson's start? Where does this environmental exposure come in? And so people have postulated that Parkinson's may start in the gut. And the reason why we've postulated this is because, one, some of these non-motor features that are gut-related, like constipation, do tend to predate these motor symptoms of Parkinson's by about 10 to 20 years. And going and studying the guts of patients with Parkinson's, we've been able to see that aggregation, the accumulation of that bad protein and the Lewy bodies in the nerves of the walls of the gut. And so we're thinking potentially that this abnormal accumulation is kind of stemming from the gut after ingestion or exposure to an environmental toxin, and then it's traveling upward, almost like a virus, through those nerves up towards the brain, and then thereafter, 10, 20 years after, you may start experiencing the motor features of Parkinson's. And so this is kind of where all of that talk is coming from. And so we talked about the motor features of Parkinson's with the two acronyms, TRAP and SMART. And so here's a list of all of the non-motor features of Parkinson's that aren't recognized enough, I think. So one of the big ones is REM behavior disorder, like vivid dreaming or dream reenactment, which is very common in Parkinson's disease and it often predates, again, the onset of the motor features about 10 to 20 years. Fatigue, depression, we talked about the quieter voice. Constipation, autonomic dysfunction is a huge non-motor feature of Parkinson's, and that includes something called orthostatic hypotension, which is low blood pressures when you stand up too fast. That also as part of autonomic dysfunction, and you can kind of think of this as the automatic things that need to go right in your body. Sexual dysfunction falls into that category. Drooling, hallucination, psychosis, and also cognitive changes. These are all in the category of non-motor symptoms of Parkinson's. And this is a nice little picture that kind of shows you, kind of summarizes all the things that we just discussed. It's at 50 to 60% dopamine neuron loss that you start to see the more tangible motor features of Parkinson's disease. And so it's before then that it's potentially you are seeing the non-motor features like the constipation, the REM behavior disorder. But keep in mind, always keep in mind, and I wrote this disclaimer, that every patient with Parkinson's is different. And so this is kind of why we know that Parkinson's may be caused by different things or different combinations of things, because not all of you are going to have all of this, and not all of you are going to develop all of this. So please keep that in mind. And so here's just another schematic of how we approach Parkinson's disease and medication management. So at 60% of dopamine loss, you start to experience the motor symptoms of Parkinson's. And prior to that, perhaps the non-motor symptoms of Parkinson's. And what we do in terms of medication is that we want to kind of change the trajectory of this and supplement the dopamine, right, in order to help improve your symptoms of Parkinson's. The medication is purely symptomatic management. So it's not changing the course of the disease in any way, in the sense that we're not changing the underlying neurodegeneration, but we're helping you symptomatically. So we're kind of changing the slope a little bit. And so we're hoping to improve the symptoms that you're experiencing. But remember that neurodegenerative condition, the neurodegeneration continues, and we're not able to halt that, unfortunately, at this time with any sort of medication. And so that's why you see movement disorder doctors, so that we can kind of keep up with the changes and adjust your medication with time. And so here are the kind of general overview of the disease stages in Parkinson's. So there's mild, moderate, and advanced. And these are the medications and modalities that we use to treat these stages, just in general terms. So in mild disease, we use what we call levodopa-sparing agents, so MAO inhibitors like Azilect, and then also dopamine agonists like ropinirole and Mirapex. When we move on to moderate stage disease, we start to use our mainstay of treatment. The closest thing we get to a dopamine supplement, which is levodopa. And we can use the other medications kind of to smooth things out. And then finally, in more advanced disease, when things like dyskinesias come into play, or lots of motor fluctuations where the meds are really unpredictable, we resort to more advanced and invasive therapies such as intraintestinal infusions like Duopa and, of course, deep brain stimulation. And so, as you saw across the board, exercise is reinforced at every stage of the disease. And that's because we know that from some research studies that exercise is the only thing that's potentially neuroprotective and could potentially modify and slow down the progression of Parkinson's disease. So that's why we're big proponents of exercise, and I know Dr. Fleischer will talk about this a little bit more. I'll just skip over this just for the sake of time. And I wanted to talk just a little bit more about these non-motor features of Parkinson's that I think are important. One of them is speech changes in Parkinson's. And so in terms of speech changes in Parkinson's, the biggest component of this is low volume or hypophonia. Patients can have monotonous speech, hesitations, and short rushes of speech, and often they describe this as stuttering. And so there are kind of non-invasive ways to help with these speech changes. And one of the biggest ways to exercise kind of your speech and your volume is doing a therapy called the Lee-Silverman voice treatment therapy. And just practicing speaking out loud and shouting almost. And one other thing that often comes up in our patients is various nonverbal communication that can be affected in Parkinson's. And so the reduced facial expression in Parkinson's patients is often misinterpreted by people. So PD patients are described as being passive, uninterested, maybe even sad. And so we really, as caregivers, we really have to recognize that this is part of the condition and be very patient and understanding of this. And so one way to approach this is, first off, recognizing that this is part of the condition. Essentially, there's slowness in the muscles of facial expression, and really taking the time and effort to look at your Parkinson's loved one, and when you're speaking, reduce distractions when speaking to them, eliminate background noise, use shorter sentences, and really minimize non-literal language. Because there have been some research studies that have shown that Parkinson's patients even have trouble interpreting other people's facial expressions and emotion recognition. And then constipation is a huge issue, and I think Dr. Wittig might be talking about this next, but this is a huge quality of life issue that often falls to the back burner at our visits, but we have so many different ways that we can kind of attack this issue. And so please keep in mind that this is something that we want to discuss with you at our visits, and we have lots of remedies for this that we can utilize. And then just briefly, sleep dysfunction in PD can there's several levels of dysfunction in terms of sleep in PD. We talked briefly about REM behavior disorder and dream reenactment, but sleep can be affected in a lot of different ways in Parkinson's. Sleep can be extremely fragmented in general. Patients might have restless leg symptoms that are keeping them up, or just general stiffness in bed. All of this can lead to excessive daytime sleepiness and can throw off the sleep at night. And even sleep attacks can occur in response to certain medications that we're prescribing. And so we do have remedies for this as well, and I've listed some of them here. So it's really important to talk to your doctor about this stuff, because poor sleep can really worsen everything, or whether it be motor or non-motor features of PD. And so I wanted to kind of briefly touch on falls, as I as alluded to in the title of my presentation. So falls in PD, this is my own kind of research interest, and I'm interested in gait in general. So falls in PD can be very multifactorial. So they can be due to bradykinesia, which manifests usually as that shuffling gait. They can be due to postural instability, where you're falling backwards or even have difficulty getting up out of the chair, especially low chairs. And then finally, they can be due to what's called freezing of gait, which patients often describe as, my feet feel glued to the floor and I get stuck. And so freezing of gait actually can manifest in a lot of different ways. It can just be an initial start hesitation when you first get up and your foot gets stuck. It can even be a complete halt in movement when you're walking. There can be stuttering or kind of trembling steps, even in just one leg. And this usually happens during turning, cramped spaces, even as you're just approaching a doorway. Freezing can also occur during sidestepping, and so when you're at the kitchen sink or when you're cooking, freezing can come out then as well. And it can happen in the off state, the on state, it can happen at all times, and so it's very complicated. And so some of the exacerbating features to falls and freezing include anxiety. So when someone freezes, they tend to start staring at their foot, and the anxiety builds up, and they can't kind of get over it. And so that's something that needs to be attacked right on. Divided attention or multitasking can really lead to falls. So even just, using your phone or carrying too many loads of groceries in both hands. An unsafe home in terms of uneven ground and rugs, narrow areas, and lots of furniture and clutter can really bring out fall risk. The wrong use of durable equipment like canes, which are very asymmetric. And one important thing is, if you have one fall, there's a lot of fear of falling that comes after that. And that fear of falling really leads to immobility and heightened anxiety, and as a result, you're at even higher risk of falling. And so how do we kind of attack fall risk and try and prevent falls? So first and foremost, physical therapy. The right type of physical therapy is most important, but we also want to smooth out people's dopamine regimens. We want to treat that anxiety that I talked about, and that might even require the use of an antidepressant. And we want to make sure people's attention and cognition are optimized too, and that might require a medication as well. And so the rest of it, which is the crux of treatment of falls and preventing falls, is non-invasive and it's therapy-based. And so here's just a list of things that one would focus on in physical therapy in terms of falls prevention. And if anyone is interested in falls prevention and is getting a little bit worried about their fall risk, I do have a research study that's going to be starting hopefully very soon, and you can, and it has to do with telephysical therapy or occupational therapy focused on falls prevention. If you're interested, you can email us at movement-disorder@rush. And so after the rest of the slides have to do with making the most of your visits, I'll have you guys take a look at that on your own. We're running low on time. So thank you so much. I hope this was helpful.
I think what we'll do for the sake of time, we'll hold the applause for all of our wonderful speakers at the end, right before our break and after the panel discussion. I want to remind you that there are cards on your table. Please fill them out with any questions that you may have, and we will walk around and take them. The next speaker I would like to welcome is Natalie Weddick.